Good afternoon. I would like to present my PhD topic, which is improving acute pancreatitis management. My name is Dorottya Tarján, and I'm working as a gastroenterological resident and a PhD student. I have three topics. My first one is identifying early predictors for infected necrosis in acute pancreatitis. This will be a systematic review and a meta-analysis. My second topic is investigating the safety and effectiveness of cholecystectomy in pregnant women with acute pancreatitis. This will be a register analysis and an international survey. And the third one is acute pancreatitis severity prediction. It's time to use artificial intelligence, and it is a perspective article with case reports. So my first topic is identifying early predictors for infected necrosis in acute pancreatitis. Among acute pancreatitis, 20% of patients develop necrotizing pancreatitis. Secondary infection of the necrotic tissue is a severe condition with increased morbidity and mortality, requiring antibiotic treatment or even invasive interventions. The risk of organ failure is 3 times higher, and the mortality is 2 times higher compared to sterile necrosis. However, early predictors around the initiation of an early therapy have not been established yet. Therefore, our aim is to identify early predictors for infected necrosis in acute pancreatitis. Therefore, our clinical question is, which parameters can predict early infection in necrotizing acute pancreatitis? Our population was patients with necrotizing acute pancreatitis. For index test, we included any laboratory biomarkers which was compared between the two groups. And our reference test was CT imaging with the presence of gas in the necrotic collection or by examination of the sample acquired by an intervention using gram staining or culture. And our outcome was the infection, and our hypothesis was there are early predictors for infected necrosis in acute pancreatitis. We conducted a systematic search in 3 databases, and in the end, we found 14 eligible full texts. In the first 4x plots, I would like to show you the error under the curve for the CRP. As you can see, we will be able to do 2 subgroup analyses based on the time of the measurement of the laboratory parameters. As you can see in the 2 groups, the population was quite homogeneous. The error under the curve, if it is 1, we can say that we can be 100% that is correct. And if it's 0.5, we can say that we are 15% sure, it's like flipping a coin, that we are correct with our diagnosis. As you can see, in the first 3 days, the AUC is only 0.70, which means we cannot use it in clinical settings. However, in the late phase, after the first 3 days, we can see that the AUC was 0.88, which is quite a good parameter. For the procalcitonin, we will also be able to do the same subgroup analysis, and you can see that in the early phase, the AUC was also 0.70, which is clinical settings means we cannot use, and in the late phase, the AUC was 0.86, which is a quite good parameter. And in this ROC curve, you can see in the first 72 hours that both the CRP and the procalcitonin has low accuracy, but between the two, the procalcitonin is slightly better. And the strength of this study is that this will be the first meta-analysis which includes subgroup analysis based on different time intervals, and there is no significant heterogeneity. The limitation of the study that they only found small number of observational studies, but some of them was prospective and some of them retrospective. So our conclusion is, in the first 3 days, the serum measurements of CRP and procalcitonin could be evaluated without the presence of infection, and their elevated level in the late phase could be associated with infection. The implication is, for this in clinical settings, that antibiotics may be recommended in case of persistently high CRP and procalcitonin levels. And its implication that for the future we need more studies and the development of a score system for the prediction of the presence of infection. And in the first project, I'm currently working on the manuscript and the baseline table. So my second topic is investigating the safety and effectiveness of cholecystectomy in pregnant women with acute pancreatitis. Acute pancreatitis in pregnancy refers to acute pancreatitis that occurs during pregnancy or 3 months after delivery. Acute pancreatitis in pregnancy is a rare disease, and most cases in pregnancy are mild. However, 20% of the cases will be severe. The most common cause is choledocholithiasis. Acute biliary pancreatitis related to pregnancy has a relatively high recurrence rate, 70%, compared to the general population. Index cholecystectomy was proved to be beneficial in the general population after mild acute biliary pancreatitis. However, there are no guidelines currently for the management of pregnant women with acute pancreatitis. Therefore, our aim was to investigate the safety and effectiveness of index cholecystectomy in pregnant women. Our clinical question is index cholecystectomy safe in pregnant women with mild acute pancreatitis? Our population is pregnant patients with biliary acute pancreatitis. Our exposure is index cholecystectomy, and we're looking for the maternal and fetal mortality outcomes, preterm delivery, recurrence rate, the severity of the second acute pancreatitis, and the need for ERCP. Our hypothesis is that index cholecystectomy is safe and reduces the recurrence rate of biliary complications. My third topic is acute pancreatitis severity prediction. It's time to use artificial intelligence. The clinical course of acute pancreatitis can be variable depending on the severity of the disease, and therefore prediction for organ failure is really important to initiate adequate treatment. And there are multiple options to do risk stratification. The first one is univariate biomarkers, which has low accuracy, therefore they cannot be used in clinical setting. The second one is a multivariate score systems, for example, BISAP score or Apache score. And while they had a better results, better sensitivity and specificity, most of them require multiple not daily measured laboratory parameters or more than 1 day to be able to complete it. And our other option is artificial intelligence. Artificial intelligence can For this, we can use the EASY app, which is the first application for severity assessment for acute pancreatitis. It uses multiple continuous variables and calculates a risk score between 0 and 1 while explaining the prediction of the machine learning model. And it doesn't require all the parameters at the time of the admissions, therefore it's easier to use, and there is no information loss since it uses variable continuous biochemical parameters. And it has been published in December. So an overview for my project. The first one, I'm working on the manuscript. The second one, at the end of April, I hope I will be able to send out the international survey questions. And the third one was published in December. Thank you for your attention, and let me finish with a quote that hope is the thing with feathers. Thank you.
I have a couple of comments and questions. That tell the truth, I'm a surgeon, and in the last 20 years, I don't remember that we performed an index cholecystectomy, early cholecystectomy in pregnancy because of after biliary pancreatitis. So it's a huge project to find the patients who had a biliary pancreatitis in pregnancy and got a laparoscopic cholecystectomy. So good luck to find these patients. The other is that, do you know what is the recurrence rate generally in biliary pancreatitis?
I'm not sure that I'm correct, but I think it's 20% in the first month.
20%.
Yes, but it's depending lots of the time by the type of stones.
Yes, because I'm thinking that it's laparoscopic cholecystectomy has several complications, can have several complications. For example, in general case, the conversion rate during laparoscopic cholecystectomy is 4%, and I'm sure that it's much higher than in pregnancy. We don't like to do any operations in pregnant women, so maybe this is the other reason that there's very few patients, I think. So I don't dare to operate the patient after acute biliary pancreatitis with early cholecystectomy. Maybe for me, I should wait the end of the pregnancy.
Yes, so all of the articles that I read, they all stated that there is really, people don't like to operate in these patients, but like in retrospective analytical studies that they found that if the patients have early symptoms, and it could be like cholangitis, cholecystitis, coliac pain, they found that if they had a surgery, there was less complication and hospital stay both for the maternal part and the preterm part, and so they recommend that there should be a surgery for these patients, but also there is only a low data for this.
I think the main problem here is that we don't see the data.
Yes,
we don't see the data which can convince us, and I sympathize with your aversion to do an operation on a patient who has got, you know, a little human being in the abdomen. You know, you risk 2 lives at the same time. And that leads on to my question regarding your second project. Are you going to measure birth-related issues, complications, and kind of outcomes that are important from the newborn's point of view or breastfeeding point of view? So are you going to measure these outcomes in your analysis on, because I think that's the key thing here. Is this safe from the baby's point of view? We know that, you know, laparoscopic cholecystectomy is safe from an adult's point of view, but is this safe from their point of view?
We will also investigate like the fetal loss or preterm birth and also the rehospitalization which could affect it, or any complication after birth for the baby.
I think you should measure outcomes like, you know, need for neonatal intensive care in these newborns and things like that, because that can be convincing data. You know, if you see very little issues or same number of problems in both cohorts, then there's no concern. But if you see more in one cohort, then truly that can be a decision-making fact.
I'd like to ask you a question about your third topic with the use of the Easy app. So if I understand correctly that the high performance of the Easy app was validated for pancreatitis in general, and the question now is, does that still apply to this subgroup of AP pregnant patients? And if it's about this, so to test this app on this specific subgroup, do you see a way to maybe if it doesn't exactly perform as it does in general, so do you see a way to maybe draw conclusions about what's the difference between the subgroups? So how can this artificial intelligence inform us of the differences we might observe?
So for the Easy app, we can also use it for pregnant patients because like the laboratory parameters are quite similar. But as a clinicians, we also need to include the picture that we see before us. But so with pregnant patients, the main issue it isn't the prediction of the severity, it's the management, what happens after we treated the acute pancreatitis.